this computer. Okay. So you've got another 30 seconds if you want to chat. Let me hit on the chat as well. So I've got that going.
Well, presumably we're going to say hello to each other and so on.
Yes, yes. Yeah, I can do that. Okay. All right. I haven't written this in my head. Good evening, everyone. My name is Dr. Sarah Coll. I'm an orthopaedic surgeon based in far North Queensland, and I'm the current president of the Australian Federation of Medical Women. Tonight is my great honour to once again take the opportunity to interview Professor Caroline DeCosta, who in my mind requires no introduction. However, I can divulge that she's an obstetrician gynaecologist, and she's a wonderful writer of mysteries, which are based in my hometown, for which I am truly grateful. And tonight we're going to talk about a well-worn topic, which is caesarean section. And I think we're all very interested to hear her perspective on the history and the process of decision-making around caesarean sections. All yours.
Sarah, yeah, very nice to be with you again. And yes, as you've kindly pointed out, I also really belong in far North Queensland, although I'm now in the process of retiring to Melbourne, where I am now. And it is very cool down here. So I'm going to talk about a few aspects of caesarean section that have become obvious to me over the last couple of years. I no longer practice clinically, and I've also given up being the editor of the Australian New Zealand Journal of Obstetrics and Gynaecology, but I did that for 7.5 years. So I feel that I'm quite well informed about caesarean section, and I've always been interested in it. So I'm going to tell you a few things this evening that may be reasonably new to the audience. And first of all, of course, caesarean section is a procedure for safely delivering a baby while avoiding a vaginal birth. And it's worth noting that this operation has only been safely available for less than 150 years. So for thousands and thousands of years, women with obstructed labour or malpresentations or conditions like placenta previa inevitably died after a long drawn out or really horrific labour because there was no alternative to what nature was providing. So the first, I know what you want me to say, or the question you want me to answer. Was Julius Caesar born by caesarean section?
Was Julius Caesar born by caesarean section? Correct. That is my first question. Look at that.
And the answer is no, definitely not, because we know his mother was Aurelia. She was a Roman noblewoman. And he was born, I think, in 100 BC. And I think he died in 44 BC, something like that. But we know that he wrote her letters home. I'm not quite sure what he wrote on, but something from Gaul and Britain as he went off conquering to found the more stabilize or establish the Roman Empire. And certainly if she had given birth to him by caesarean in 100 BC, she would have not survived.
She would have expired.
Yes. So the best explanation I've had of the word caesarean, I mean, it's a strange word. You're actually taking a baby out of the abdomen. Why is it called caesarean? Is related to the Latin word sedere, to cut. And for hundreds of years before Julius was born, it was the common practice to, because women did often die in childbirth, and to bury them, it was necessary to remove the infant, which was also dead, post-mortem, and bury them separately. And so these infants were cut from the womb. Now, mostly they were dead. I would say mostly they were dead, but occasionally there was one which was, there was still a flicker of life. And when the child was delivered, it survived. And in the past, in Julius Caesar's family, there had been at least one of these caesones, which had been born alive from a dead woman. And so the family got the name of Caesar. So Julius got the name of Caesar rather than giving the name of Caesar to the operation. that's the best story I've heard. There are a few others, but none of them are very plausible. So the first, it was obvious to people down through through medieval times and the 17th century, 18th century and so on, that being able to open the abdomen in the case of a woman with obstructed labour and take out the baby while the baby was still alive, and then somehow repair the abdomen and have a live mother would be a great thing to do. People tried it, but of course the result was terrible hemorrhage, terrible infection, and almost inevitably death of the woman and indeed of the baby. So there were attempts made, and they're recorded down the years, to do this. And there are also lots of myths about Greek gods and Hindu gods and so on, who were supposedly born in this way. But there was no really well-recorded successful surgical birth until 1879, when a man called Eduardo Porro, who was a Italian surgeon, he performed his operation in Padua on a woman who's described as a rachitic dwarf. She had rickets as a child.
Yes.
And so she was only 4 feet tall. She had a very twisted and small pelvis. The pelvic rim was said to be the size of an espresso cup, an Italian way of looking at it, whereas the pelvic rim in the average Australian woman is 10 centimetres in diameter at least. Anyway, Porro carried out his operation successfully. He made a midline incision and delivered the baby, who was alive and well, and then he performed a subtotal hysterectomy, which sounds counterintuitive, but it actually removed most of the uterus, which was what bled, and it was able to drain then partly through the wound itself and partly vaginally. He also had the benefit of antisepsis. He was aware of the need for antisepsis, and he was aware of the need for anesthesia. And so the woman was given chloroform. So both those things were essential for any progress to take place in the development of the caesarean operation. So he was the first successful one, and then subsequently a lot of other people jumped onto this important bandwagon and developed over about 80 years up to the middle of the 20th century the operation, which is now referred to as the lower segment caesarean section, but we've still got the word caesarean. And maybe it's the combination of surgery and birth that keeps this separate word. We have nothing else like it in medicine than this term caesarean. And it will stay, I think. It's in all languages,
All languages.
It's always caesarean. Yeah.
And it's abbreviated to a Caesar as well. So
yes,
so
that's
it's
right.
got absolutely nothing to do with its own origins.
No, nothing. No. So that's how the name came about, and it's now a very common operation.
So what is the caesarean rate in Australia, and is there a good caesarean rate?
Well, when I began training in obstetrics and gynaecology, which is now more than 50 years ago, the caesarean section rate in countries like Australia and in Ireland, where I was training, it was about 8% of all births. And it has risen significantly in 2023. The rate in Australia was 38% of all births, which is getting on for 2 out of 5. Is there a correct caesarean rate? This is a topic of enormous discussion and much polarization. In 1996, WHO, the World Health Organization, issued a statement saying that the recommended Caesar rate should be about 15%. This was not based on any particular evidence, although it was half the lower rate of 8%, which we'd had earlier on in that century, and the rate then in countries like Australia and the United States, which was about 25%. And this 15% rate was widely quoted, and countries and maternity services with higher rates were heavily criticised in the first decades of this century. And there were major attempts to decrease the rate and bring about what was called normal birth. For example, in the UK, the Royal College of Midwives had a campaign for normal birth starting in 2005. And the New South Wales Health Department had one called Towards Normal Birth, launched in 2010. However, this in turn led to several court cases and government inquiries in the UK, with a lot of implications for Australian practice. I will tell you about these, one particular case, the Montgomery case, because what was happening is that midwives and some doctors were pressuring women into persisting in labour and vaginal birth when, in fact, a Caesar should really have been offered quite early in the piece. And Mrs. Montgomery was giving birth in 1999 in Lanarkshire in the UK. She was English. She was a woman of short stature, and she had gestational diabetes, and she had a large baby, and she was concerned about her upcoming birth. And indeed, her mother, who was a doctor, and her sister, who was a doctor, were also concerned about the size of the baby. But there was never any suggestion when she asked her obstetrician whether the baby was too large, that there could be difficulties with the birth. She was reassured that it was going to be fine. However, she went into labour and she had forceps to deliver the head of the baby, a boy, and then she experienced severe shoulder dystocia. The shoulders were completely stuck. The boy could not breathe, and his chest and the umbilical cord were compressed against the bony pelvis of the mother. And it took 12 minutes for the obstetrician to extract the shoulders. And as a result, the boy developed some cerebral palsy and intellectual impairment. So Mrs. Montgomery sued and she won her case. It took a long time. She had to go to higher levels of the court because the obstetrician had not informed her of the risks for her of shoulder dystocia mentioned. And it was said that it should have been, and the bottom line of the Montgomery judgment was that all pregnant people need to be fully informed about all potential risks of all modes of birth, which of course is a lot of talking on the part of the people caring for pregnant and recording it as they get informed consent. It's not something you can do well into labour. It needs to be well before in the course of antenatal care. And then there have been two extensive UK government inquiries in Morecambe Bay and Ockenden. And people who are interested can easily look these up on the internet. And they mostly deal with staffing shortages and training and so on. But they also identified a culture of vaginal birth at any cost across the National Health Service, the NHS. So as a result of all these inquiries and the Montgomery case, there's been a concerted move in the NHS to reverse this trend. And the Royal College of Midwives have dropped their campaign, and the New South Wales campaign has been replaced with one called Connecting, Listening and Responding. And the WHO also revised their position. In 2015, they said that while a caesarean section rate of 10% compared to no caesarean section rates brings about a significant decrease in maternal and neonatal mortality, increasing the rate above 15% does not improve the rates of death for mothers and babies. However, they added that there are many other factors that should be measured around pregnancy and birth, both physical and psychological, and that one of these is the mother's satisfaction with the experience of her birth. And internationally now, there's a move away from caesarean section rates as a means of assessing measurement. And WHO has recommended that countries around the world adopt the Robson criteria, the classification of caesarean section, as a basis for identifying outcomes of all modes of delivery and not just Caesars. And I must immediately say that this has nothing to do with the current president of the AMA.
So are we using the Robson classification for caesarean sections in Australia? And can you explain to us what it is?
Yes, have you got my one PowerPoint slide?
Yes, I will pull that up, and then if I do this,
Oh, yes, they should be able to.
does that
Yeah,
work?
yeah.
Fantastic. There's a lot
So,
of writing on there. There's a lot of writing for an orthopedic surgeon, so you better translate that.
yeah, well, it's going to stay up there for a little while because we're going to go through and I'll expand on what's there. And this is the only PowerPoint slide. I admit it's quite busy. So Michael Robson is an obstetrician in Dublin, in the National Maternity Hospital, and he has devised this classification system, which is a really different way of thinking about caesarean section, and it is women-centred. And some maternity units in Australia have adopted it to assess their own performance, but it's not yet been accepted nationally. It is going to be talked about at the ASM of RANZCOG, which is in Wellington in October, and Michael Robson himself will come, and institutions across Australia and New Zealand who have been using it will be making their own presentations about how they've used it. And I actually had the pleasure and privilege of meeting Michael Robson at the beginning of May in Dublin and talking to him about, it's called the 10 group classification, so TGCS. And what it does is it looks, it's the basis from which you can look at what's happening with caesareans in your own hospital and indeed other modes of delivery. So it classifies women into all women presenting to give birth in any kind of unit, but in particular in larger maternity units, such as are found in the National Maternity Hospital in Dublin, has about 9,000 births a year. Many of the Australian hospitals in Brisbane, Sydney, Melbourne, and so on, something between 7,000 and 9,000 a year. So it looks, group one is women who are in their first pregnancy. They've got to 37 weeks or more. They have a single fetus, which is a cephalic presentation, and they start in labour spontaneously. They have had no real problems with the pregnancy, and labour is spontaneous. And the blue numbers tell you what percentage of the women overall presenting for antenatal and intrapartum care is normal for this kind of hospital. And it's 25% of women coming to the hospital are in group one. And they have a caesarean section rate in red of 7%. Does that all make sense, Sarah?
Yes, I'm disappointed to see that proportion of presentations is so low. So
well,
only a quarter of mothers present in labour at sort of term.
Yes, that's right.
Well, the first baby.
Yeah, with the first baby, yes, yeah. So the second group is also women who are having their first baby. So they're nulliparous. They have a single fetus. It's in a cephalic presentation. They present at 37 weeks or more, and then they're subclassified into A and B. And A has induction of labour. So they are people in their first pregnancy, but they have developed something, for example, preeclampsia or hypertension, or perhaps they have diabetes, gestational diabetes. And so it has been decided that they should have an induction of labour. And to B are also people who have some reason to have delivery recommended, but it is decided that they will have a caesarean section without labour. So they are all going to have a Caesar. Many of those who have induction into A will end up with an emergency Caesar. And in addition, in group two, with the caesarean section pre-labour, are women who have requested a caesarean section for either no or minimal medical indications. And so they bring up the numbers of prima gravida, Sarah, to 40% because they're 15% of the women overall, but amongst them, 36% have caesarean sections. Okay, so that's a very high percentage compared to group 1. Are you still with me?
But it's not the induction of labour that causes the caesar in that group. So that group incorporates, because there's been a decision in some of them. So it doesn't seem to separate out the induction from...
Absolutely, yeah. The baby needs to be born, has been decided, hopefully in conjunction with the woman, by her attending obstetric or their representatives and the junior staff. So group 3 are multiparous. They've had at least one child before, but not by caesarean section. They've had vaginal birth or several. And again, a single fetus, spontaneous labour, cephalic presentation isn't there, but it is cephalic presentation and spontaneous labour. So that's 30% there. And they've got a very low caesarean section rate, 1.2%, because these are women who are, have good track record.
So they've gone to term once, and now they come to term second. They're easy decisions, aren't they? You're going to get a baby from a vaginal delivery when they reach the hospital.
Yeah, that's right. And then group 4 are also multiparous, no previous caesarean section, single fetus, cephalic presentation, more than 37 weeks. And again, they're divided up as they were in the group 2, induction of labour. Now, there's not going to be a lot of those because they are, women who are reasonably, experienced at pregnancy and birth. And also there'll be some pre-labour caesareans. Now, amongst those will be some who've, perhaps developed diabetes, of high BMI, that kind of thing. You're also going to have some women there who had a terrible experience with their first labour and delivery, and they have just said, I'm not going to do that again. I want to have a set. And those women overall, both those who are being induced and those who have a pre-labour caesar, are 10% of all the women coming to the hospital, and they have a 14% caesar rate. So that's not too bad.
Still low. That's still low.
It's reasonably low. Then we get to group 5. And group 5 have had one or more previous caesars. They still got a single presentation. It's a cephalic presentation. And they're 37 weeks or more, so they're at term. These people are only 10% of all the women coming in, but they have a 68% caesar rate because I've got two
questions about that, because does that mean if you have a caesar, you're not likely to have another child, and that's why they're only 10% of the population? And then the second one is, should that number of 68% be 100%?
Oh, well, I don't know that it should be, but there are institutions where it will be, because there won't be any attempts. There are parts of the United States where vaginal birth after caesarean section is simply totally discouraged. I'm going to talk about that more further on.
Fair enough.
But group 5 are the people, one of the groups that is really putting up caesarean section rates wherever you start to look at them. Group 6 is only 2.4% of the women coming to the hospital, and they are nulliparous breaches, their first pregnancy breach. And there's a lot of agreement after the term breach trial, about which there has been argument, but given that the term breach trial was so definite about the need for caesars for breaches, it's very hard now for obstetricians to have enough experience to manage a vaginal breech birth, and also for them to be happy about doing it, and for a service to be able to provide a continuous service to look after women who want to have a vaginal breech birth. So 94% of nulliparous breaches are going to have caesars. And the same thing is true with the multiparous breaches in group 7. They're only 1.4% of the total population of women coming into the hospital, but 90% of them will also have a caesarean. Then we get to multiple pregnancies, and they are about 2.5% of the women overall, but they have a very high caesar rate, 65, nearly 66%.
Is that decided before the labour? Is that an elective Caesar in the multis?
I think increasingly across Australia, it's starting to happen. It is less and less common, particularly unless you've got two cephalic fetuses. I think that, then you might have a vaginal birth of both of them, but multiple pregnancies increasingly are being treated with elective Caesars. Group 9 is all abnormal lies. That's a very small group. This is transverse lie or oblique lie. And 100% of those will be Caesar because they simply cannot get out any other way. And then group 10 is all single cephalic pregnancies at 36 weeks of pregnancy or less. They are about 3.7% because some of the earlier fetuses are going to be in group 8 as well. But they have a high Caesar rate of 65%. So what we're seeing is that one of the things that Michael Robson also emphasizes is that this is just a structure on which you put all the information you gather from very meticulous auditing of your own performance in your own hospital. And he says it's necessary to continuously collect accurate information about every pregnancy, birth and post-birth period, and use the information in decisions about standards of care and proper improvements to care. And increasingly, certainly throughout Scandinavia, in the United States, a lot of places are using it, the United Kingdom, Canada, and hopefully we are moving towards it in Australia, in that it's much easier to see exactly where your how figures fit in with these approximate ones that are provided from the National Maternity Hospital in Dublin. And if you want to be trying to reduce rates, and you can argue that that might be a useful thing to do, you've got to look at I don't know whether the cursor is acting as a pointer, but you need to look particularly group 2.
No, I can't get it.
Where you've got induction of labour for a number of reasons, and pre-labour Caesars, which may or may not be for medical reasons, because they are the people who will then come back if they're going to have another child, and very likely appear, well, they will appear in group 5 if they're having another child, and very often they will elect to have a repeat elective caesarean section. And that is really the main thing. The last 4 things, the last 5 things, group 6, 7, 8, 9, and 10, all have high Caesar rates, but individually they're quite small percentages of the overall number of women. So
25.
What increases the rate significantly is the decision to intervene in the first pregnancy, and then secondly, a later decision to proceed to Caesar for subsequent births. And Michael Robson's got a few things to say about, it's really based on his experience of being an obstetrician, about request for a caesarean section when there's no major medical reason. Nulliparous women request a caesarean section because they're worried about something that might happen. Multiparous women request a caesarean because something did happen. And I think that is very, very accurate. And he also says that, look, most women requesting a caesar don't want an operation, really, but they simply want to avoid a vaginal birth. And my experience goes with what he says, which is it's not so much fear of labour pain per se. It's what will happen. Will there be many hours of fruitless labour, tears, damage to my pelvic floor, delivery by forceps or vacuum, an emergency caesarean? And these are all the reasons, I think, why women are now looking at requesting a caesar in a first pregnancy, or requesting one in the next pregnancy if they've had a bad experience in the first pregnancy, or requesting a caesar after they've had a previous elective caesar. Certainly anyone who has an elective caesar the first time, but for that type of reason, is going to have a caesar the second time if they have another child. Of course, women are having fewer children, so that is an important thing. If you're only going to have one child and you want to have it by elective caesar, then your risks of complications later on are going to be zero, because you will not be having enough. So you can take all that in to consideration. And many women are doing that, obviously. You asked me about
VBAC.
Yeah.
Yes.
Vagina section.
So there is so I think it sounds like carrying on from that enormous push to have natural birth, there is probably what seems to be a carryover, which is having a natural birth after a caesar, particularly, I guess, if the caesar was, like you say, with the vaginal birth was unpleasant, so therefore they want a caesar. Let's say the caesar might have been unpleasant, now they want to try a vaginal birth. So what proportion of women do this, and what proportion of those who've had a caesar will actually get on to have a vaginal birth?
Yeah, so about 80% of Australian women who've had one or more previous caesars, and it's fairly unusual to try for a vaginal birth after two. There are many units which will not care for a woman. That's it. We will strongly discourage a woman from doing that. So 80% of women who have had a previous caesar will choose an elective repeat for the following pregnancy. And most of them will just have had one prior caesar, and they don't intend to have more than two pregnancies. So they're likely to have quite a low risk operation if they have a repeat elective. Obviously, the risks are not zero, but they will be fairly sure of having a safe procedure. And the other 20, perhaps 30% in group 5 who do attempt a vaginal birth after the caesar, of those about 70%, it varies from one institution to another, will have a vaginal birth. I really don't like to use the word successful, because it is not a success or failure thing that you can study for, or an exam do it for. It is entirely up to nature. So women who would qualify for an attempted VBAC, they haven't been studied very much in Australia, and there are some for whom a repeat elective caesar is clearly medically appropriate. They've got diabetes and it's got worse than it did the first time, or they've got hypertension, or they've got repeat preeclampsia, or they had wound breakdown and a difficult time with the last caesar, and the scar may not be very strong. There are various medical reasons why a woman would be recommended to have a repeat caesar. There are also services that won't offer an attempted VBAC because they've got to have access to the theatre 24 hours and appropriate staff and so on. There's also, a significant number of women are making that decision. If the caesarean section rate is 38%, a significant number of people are women, and people who are pregnant are deciding that they do want to have another elective or an elective caesarean section with really fully informed this is really a fully informed decision that they're making. They're not being pushed into it at the last moment or because of some service requirement. That is actually what they want to have. There's never going to be a randomized controlled trial to determine which is best, attempting or having a repeat elective Caesar, because women are never going to agree to be randomized. And it's just of course not. It's not. It's
but
not
you
something...
also can't randomize, but then you can't also standardize the population either. I mean, the number of factors between the start of labour and the delivery, there's too many factors to try and standardize, which is presumably is the problem with all obstetric and early childhood research, is trying to standardize and then trying to randomize.
Yes, anyway. Yes. Yeah, all you can do is observe what happens to women, both these groups. But the risks for a woman who's going to have an elective caesarean section on a daylight operating list in an operating theatre where people have had enough sleep and they know what their job is and there's enough time to do it and the fetus is not distressed, they should have a fairly low rate of complications of that surgery if it's a first or second caesarean. It won't be zero, but it should not be too high. And anaesthetics are getting more and more, they're safer and safer. Surgery is competent. It may be a perfectly reasonable decision to make. I'm not judging. No. I'm simply
observing, as we said before. So does that lead us to what are the reasons behind the rising rates of Caesar in Australia? What is the rate of rise? We've gone from something like 15% to 38%. Is that what you said?
Yeah. So it was about 25% at the end of the 20th century, and just last year, 38%.
Okay.
So there are various reasons. First of all, the increased age at which women are having their first child. And in 2011, this was age 30. In 2021, it was 31.1. And in 2021, also, 25% of women giving birth, they'll be both multiparous and prima gravida, were aged over 35. That's quite a high proportion.
The second. So 20 years ago, what was it? What was the average age of, should we say 50 years ago? It would have been about 25, or would it have been 20?
Closer to 20. Yeah, more like
20.
The first child at 22, 23.
Right, and now we're up to 30. Go on.
Yeah. And in addition, about 50% of the pregnant population of Australia is overweight or obese, with a BMI greater than 30 at the start of pregnancy. And some studies in rural populations in Australia show figures as high as 65%. So many of these women, although not all, will have type 2 diabetes before they start, or they'll develop gestational diabetes. So they're more likely to have macrosomic fetuses, for whom induction of labour with its possible sequel of emergency Caesar or pre-labour caesarean are likely to be recommended. So there you've got a very pertinent and for the moment permanent reason why the caesarean section rate is high.
Well, we'll have to see what happens with medication like Ozempic.
Exactly, yes. Meanwhile, caesarean section in women with high BMI has been challenging for all, and it's really desirable that women of high BMI are cared for by experienced and non-judgmental staff in an appropriately equipped operating theatre. It may be difficult for the anaesthetist to put in any kind of regional anaesthesia. Ultrasound is helpful here. It may be difficult to put an IV line in. Again, ultrasound is helpful. It will be difficult to lift the woman onto a theatre trolley and then onto the operating table and make sure that she's safely and securely in place, and then move her again once the surgery is done. You need strong, capable, practised, non-judgmental, whose own welfare needs to be considered as well. And then there are now, fortunately, various mechanical aids. When 10 years ago, 15 years ago, when we began to see more of these patients, it was necessary to get 2 medical students to go to the theatre with you so that you could lift up paniculus of fatty tissue, the ape, and hold it out of the way. And you had your 2 medical students each side of the anaesthetist with a strip of elastoplast pulling hard throughout the operation so that you could actually see the part of the abdomen through which you wanted to make your lower fan and steel incision. There's now something, and I have to say that I missed out on ever using it, called a Traxi. It's a drape, a stick-on drape, very strong, clear, and it lifts the paniculus up, and it's described as abdominal surgery with improved patient dignity. And I think that's important. It's many women, with high BMI are reluctant to present for antenatal care, and and have bad experiences. And that is something we really need to avoid if we're going to provide the best possible care for pregnant people in this situation. We also need long surgical instruments quite often to be able to reach the uterus and open the uterus and get the baby out and sew the uterus up again, and good light. And because the baby is often large, the fetus is often macrosomic, it's not uncommon to tear the uterus more than you expected when you made the uterine incision, and extra time may be needed to complete the repair of these tears. So all in all, when all this has to be done, it is better to have people in this situation, pregnant with a high BMI, in appropriate units where there are experienced staff and all this equipment necessary, and hopefully to be able to perform the operations on in daylight on a list rather than in the middle of the night. And everybody from that. Yes. So, and it also means the people running the theatres, the administration, know how long they need to allow for these procedures to be done, and don't not have to fit them in as emergencies. And all these things need to be considered in running a health service.
We've got a few more minutes to ask you about the gut microbiome. I do want to hear about that. Have you got a chance to tell us about that?
The microbiome, yeah. So
of the infant.
Yes. So you will already know, everyone who's listening, that we have lots of microbes in our mouths and vaginas and skin and so on, but particularly in the gut. And it was thought until recently that the fetus in the uterus with the membranes intact, that there were no microbes living within the baby's body. Although more recent research suggests that, in fact, there are small numbers of bacteria which do get across the placenta and take up residence in the gut of the fetus.
Oh my goodness.
Yes, yeah. This is the subject of a lot of research. This new discovery of what the microbiomes might be doing. So basically, the infant about to be born doesn't have a gut microbiome. He or she has to develop it. So during vaginal birth, once the membranes rupture, the baby is exposed to a range of microbes from the mother's vagina, in the birth canal, as birth takes place. And these migrate onto the baby's face and mouth, and they're swallowed and they take up residence in the baby's gut. And they multiply rapidly over the first few weeks of life after a vaginal birth, so that the baby establishes its own gut microbiome. And the particular microbes that are helpful and useful are Bacteroides and Bifidobacteria. And then if the infant is breastfed, more bacteria, particularly lactobacillus, are also acquired, and they acquire other bacteria from everybody who handles the baby, both staff and then family and partners and all those things. And then once breastfeeding ceases, the baby's microbiome becomes home to a general population that is similar to the people that the baby is living with. And those bugs help develop the immune system in the infant. But it also seems that they may have a role in developing the brain. And it seems that the human body has adapted to receiving specific signals from the microbes at certain critical times in early life, and that this process is necessary for the normal growth and well-being of the immune system later in childhood and in adulthood. I would point out strongly, though, that research in this area is still in progress. What happens with a caesarean? Well, if you have a caesarean, which is an emergency, then usually the woman has been in labour and her membranes have ruptured, and so there's been some exposure of the infant to the mother's vaginal microbiome. But if you have a planned caesar with no membrane rupture, there is none of that. And the microbiomes of babies born after planned elective caesars with no membrane rupture are different, and they have less of the bacteroides and less of the bifidobacteria. And there've now been good follow-up studies, particularly from Denmark, looking at the outcomes for children born for as far back as 40 years. They have excellent records in Denmark of birth and of the incidence of a number of different childhood conditions. And the two very large studies have been done in Denmark, and they show that the first study showed that there was an increased risk of asthma and rheumatoid arthritis and inflammatory bowel disease among children born by caesar compared to children born vaginally, and also an increased risk of acute lymphocytic leukemia, which is a condition that may have origins in a disordered immune system. And the second large Danish study, which ran from 1977, the records from 1977 to 2012, 2 million people, they also found that there was an increased risk of type 1 diabetes and celiac disease amongst the caesarean born, and particularly those born by elective caesar. Now, these are associations, they're not causes, but they are very, they've been replicated in other studies in the UK and Sweden and other places. And this is really interesting work. It is obvious that not just the lack of the microbiome, there may be genetic influences, infant feeding, other environmental factors, and so on. There's also an association between autism spectrum disorder in children born by caesar and in comparison to those born vaginally. And these are children in Sweden, again, Denmark and Norway and Finland in a very large study, and Western Australia, done prior to 2004. So this is all, just to sum it up for you, Sarah, this is all work which is showing that an elective caesar may come at a price, which may be one of these, or one or more of these conditions in your child. Can you do anything about it? Well, it's known that probiotics and prebiotics may increase the good bacteria and good bugs that you've got in your microbiome. And so if you're having a planned caesar, stocking up and feeding yourself on probiotics and prebiotics is one thing that you can do. Another way to do it is with vaginal seeding, where you Yeah, you swab your vagina.
Yes. What are you, I'm waiting with bated breath. Go on. What are we doing next?
Face and mouth and skin. This has actually been looked at scientifically. And it's also clear from social media that some mothers are doing it anyway. It's not really recommended because you can also get vaginal infections such as herpes and chlamydia and thrush and so on. And the other thing is that with vaginal seeding, what you're doing is putting the vaginal microbes onto the baby, whereas it's the gut microbes that you really want to be in the baby.
I don't know that we want to take it that far, do we?
No. So,
who's going to consent to that study?
So it's thought that in fact these gut microbes start getting into the birth canal towards the end of normal vaginal labour, or normal labour and vaginal birth, and rapidly multiply. And so it's thought that perhaps seeding gut microbes to babies born post-Caesar might work. And this is also a work in progress. Fetal microbiota transplantation, FMT, is a process that transfers healthy human feces from a donor to a child by colonoscopy or by capsules. These are called poo pills, taken by mouth. And look, it's used already for older children who have various severe diarrheal diseases, so it's not totally wacky. But for infants, it's still a research question. But there's no doubt that if you're going to have a planned pre-labor Caesar, feeding yourself a diet which is high in vegetables and fiber and probiotics will not do you any harm, and it may do you some good. Whether it will rapidly increase the percentage of good microbes in the baby's gut has yet to be determined. It's all topics for research.
Well, thank you very much for that. I can see I've still got 8 minutes. So Ruby, you have got an opportunity to ask any questions. Ruby Curtis is a fabulous GP in the ACT, who is part of our committee or our council. You are welcome to ask a question, Ruby, but you're not under pressure because I do have a question lined up. But you will have to take yourself off mute. Are you shaking your head vigorously because you're on mute? Oh, and I can't read your lips, Ruby.
I don't think she's got a question.
You're out? Okay. So can you just, I know we've only got 7 minutes and we've probably sort of got 6, but consenting for natural birth, is that even possible? I mean, what is the process of consenting for a natural birth? Well, the complications it's the most dangerous thing a woman ever does.
Yes, that's right. And this is now getting a lot of attention because we now have the terms obstetric violence and obstetric trauma, particularly in New South Wales. And this is also happening in the UK, which also everything that happens in the UK in obstetrics impacts on Australian practice and New Zealand practice as well. So the New South Wales Upper House of Parliament has a committee who have just conducted an inquiry into these the incidence of obstetric trauma and obstetric violence. And I spent some hours last week reading the report. It's a very, very long report, and it has 48, I think, recommendations. And I was expecting to have really terrible stories of crushed skulls and botched vacuums and things like that. A very large amount of it is a lack of communication. Women have things done to them in a hurry by people that they have never met, who barely have time to introduce themselves, let alone explain what they're about to do and get consent for it. And this is 3 or 4 procedures. One is episiotomy. The second is either forceps or vacuum extraction. 11% births in Australia are either forceps or vacuum, and they're mostly for women having their first child, or it's a caesarean section. Caesarean section, and they may have attended antenatal classes, they may have read about some of these things, but the kind of information that they're getting is not sufficient for them to understand at the time. And this is often after many hours of labour, many hours of pain, exhaustion, fear, and so on. They're being subjected to things that they feel, and rightly so, they haven't really given informed consent to. And that seems to be more what is happening behind these terms, rather than it somehow
physical sort of trauma.
Yeah, I know that Ranscock has said, look, this language is very inflammatory, and it implies that physicians are deliberately inflicting violent acts upon pregnant women. It's more that they're women are not being adequately prepared. A lot of the recommendations from the inquiry say that there needs to be much better antenatal education, and every woman or every pregnant person should have this education. But given how long it takes to become an obstetrician or a midwife and understand what these things are, it's hard to think that women are going to have a huge amount of information with them as they enter the birth suite for the labour or the birth, whatever they're going to have. And that we would even have the staff and the wherewithal. A lot of money would need to be put into it. And even then, you can have complications. You can think you can deliver a baby with forceps, and you perhaps take the woman to the operating theatre because you're not quite sure, and then it's not possible, it's not safe, and so you have to switch to doing a caesar. And explaining all that while getting it organised with the staff around you and safely delivering the baby is very challenging. I do think that there is a definite place for much better debriefing afterwards. Women. Look,
it's almost as if once the baby has appeared, then all things must be good.
Well, you hope so, because you hope that what you've done has reduced.
The absence of a debrief suggests that you should feel like it's all good now. The baby's out.
Yes. But if you don't have the debriefing, or if the debriefing is inadequate, the woman unfortunately goes home feeling that she's she's been badly treated. She doesn't understand what happened or why it happened. And she certainly wants to avoid experiencing the same thing again in another pregnancy. And her partner may also feel exactly the same.
Of course.
Yes. I mean, I don't know what kind of response the upper house of the New South Wales Parliament would have got if they'd said, would women who had excellent experiences with the health, with the maternity services, please write to us as well. Would they have got another 1,000? I don't know.
Maybe.
It is. It's not. It's not a random sample of women. It is women who were asked to say what they did, but 44,000 of them did not have good experiences.
Responded
in their estimation.
Ruby, did you want to contribute at this point? I noticed you've taken yourself off mute.
Oh, no, right.
No, it's fascinating.
Yeah, yeah, I agree. It is pretty fascinating. And I must, so am I allowed to put in a plug here for your book, Caroline, in that I bought your book. I went to a bookshop and I bought your book about Caesars before my baby, hoping that it would give me clear instructions on how to make which option I should choose. And you managed to write an entire book that did not tell me whether or not to have a Caesar or a vaginal birth. I thought that was quite masterful, really.
Oh, well, I'm sorry about that. But yes, I don't make this people. I just give them information. Hopefully they're well informed. But I've stopped practicing now. Yeah.
No, but it was a very informative book, and I did feel that I knew what I was talking about a little bit more comprehensively, not being an obstetrician, when it came to making a decision. So thank you for that book. So thank you again for your time, and thanks Ruby for coming along. And as you both know, we will be recording this and distributing it on the socials for anyone who wants to have a bit of a look. And thanks for being part of the Australian Federation of Medical Women, Caroline. Your contribution is very gratefully received. And I look forward to
great pleasure.
I look forward to our next chat. Likewise. And I hope to see you in person soon, both of you. So thank you.
Thanks for inviting.
Thank you for your time.
Thanks, ladies. Bye.